Hello and welcome everyone. I'm Reem, your host for today's episode of Unscripted interviews where we advocate for data driven research. In this series, we demystify the fundamental principles behind successful research initiatives, going beyond the surface to take a closer look to understand the secrets that lead to groundbreaking discoveries. We go behind the scenes, we bring experts in the field to share their unique insights, hear about their journey, and provide a glimpse into how they envision the future of science and data. Today, I'm beyond excited to have a dear friend and scientific partner of mine for the past decade joining us. He's a pediatric infectious disease physician with a deep passion to make an impact in both clinical care and research in the field of neonatal infectious disease. He made significant contributions in science during his highly productive 18 years between BC Children's Hospital in Vancouver and the Telethon Kids Institute in Perth in Australia. For the last 3 decades, his work has focused on neonatal and infant responses to infection, vaccination, early life interventions, and ontogeny. His novel, but often against the dogma ideas and discoveries were published in more than 250 peer-reviewed scientific papers, and one of his most groundbreaking discovery is related to the non-specific effect of vaccines in newborns. He is one of the international leaders in vaccinology. My guest is deeply committed to improving the health of newborns right from the very beginning of their lives. His entire career is dedicated to finding better ways to protect and enhance the lives of the mothers and their babies, especially in populations that fight against the odds. He collaborates with experts around the world across different fields, from vaccines to system biology, neonatology, pregnancy care, all with a common goal of ensuring a healthier start from conception and even before to the first days and years of life, the critical first 1,000 days. Since September of last year, he's back to Canada from Australia and took on the prestigious role of Professor of Pediatric Infectious Disease and Microbiology, Immunology at Dalhousie University in Canada. So, without further ado, our unscripted followers, please join me to welcome Professor Tobias Kollmann from his home office in Halifax.
Hello.
Toby, hello. Thank you so much for accepting the invitation. It's really great to have you with me today.
Thank you. It's a pleasure to be with you.
Thanks. And the life-sized Albert Einstein
Yes.
background really reminds me of the first day we met in your office at BC Children's Hospital. It's really great memory.
Yeah, it's
So,
been a while.
Toby, yeah, it's been a while. So let's jump in right into it, Toby. Can you share with us a bit of your background?
Like childhood kind of background
Yeah,
already.
yeah, wherever you want to share, we are here to hear your
Well, I
story.
was born and raised in Germany. I had a fantastic family that brought me up. I was the youngest of three, and my two older brothers, they were both 4 and 8 years older than me. They really protected me, and so I never really got into trouble for much of what I did. At least not with the outside world. Yes, with my brothers, but given that they protected me so well, I also kind of grew up without the fear of consequences. That's a good and or bad thing. But I until today, I have that in me where I think about potential consequences after I started doing something, which sometimes is not helpful, but it does give me this attitude of yes, we can, and that's still driving me today. And that's really thanks to my childhood upbringing, especially my two brothers and my parents.
Thanks for sharing this. And I can agree with you about this fearless I can attitude. I witnessed it before while working together. So now let's switch gears and talk about your journey into science and medicine. Were there any experience or people throughout your life or early life that really sparked your interest in science and medicine?
I have to admit that I had not, as a child or as a youngster, I did not have much interest in science at all, really. But in biology in high school, I learned that athletes actually trained according to a systematic understanding of how they should be training. So the fact that there was science driving how athletes operated at the elite level was what totally got me, because I was a complete sports jock. I mean, this is pretty much all I lived all day long. And when I realized that biology and research into biology really was what made them as good as they were, that hooked me on science completely.
I love this connection, Toby, between your interest in science and athletics. And I know for a fact that it's still really essential part of your daily family routine, which I find amazing. I hope I could do that as well. You inspire me, you and your family, for that. So before we dive deeper, can you tell us what really inspired you to focus on early life infections and the field that you mostly are interested in?
Yeah, I mean, there's actually, strange enough, a very concrete string of experiences. I was in medical school, and early in medical school, you do clerkships where you're sent around to do something, little clinical work in the hospital. And my brother was positioned as a physician in Ethiopia during the famine time, and I was able to arrange my clerkship to be there with him, which was very fortunate. On my way out, walking across the Frankfurt airport towards my gate, there was the security wasn't as tight back then as it is now. There was a newsstand right there. And I remember walking past, so this is in the early 80s now, and the Newsweek magazine had an article there that said the faces of AIDS. And it was really meant to show that this weren't just white gay men, which is what was commonly believed at that point, but it could be anyone. It could be black, white, it could be male, it could be female. But I remember that page clearly, it showed only faces of adults. And so that was the beginning of the AIDS epidemic, or the early stages of the AIDS epidemic. And I flew to Ethiopia, where I worked in Dilla, was a town. It's on the truck road between Addis Ababa, the capital of Ethiopia, and Nairobi, the capital of Kenya, which is where my brother was stationed. A small little village hospital, regional hospital, really. Um, and since it was on a truck route, there was a lot of truckers, and with a lot of truckers in that region, at least also a lot of prostitution, and with it a lot of sexual transmitted disease. And as a clerk there, I was there for a combined almost 1 year. I saw every sexual transmitted disease in the books in its worst expression, really. Um, but one of the experiences I had there was a pediatric nurse who took me onto the wards and walked me through, because I was interested in pediatrics in general, just as a field. And she showed me these children that she called them chipmunks, that they had like swollen like cheeks like this. I mean, and she said, I noticed that these kids die more frequently than she's used to, and she had been doing this for a while. And she was just mentioning that to me, and I noticed it, but I was a medical clerk in second year of medical school. I had no idea. And I don't think she realized what she stumbled upon either. On my way back to Germany, so almost a year later, I walked across the same Frankfurt terminal, exactly same newsstand, exactly same news rack. And again, the Newsweek magazine this time showed the cover titled Kids with AIDS. And on the front page of that Newsweek magazine was a young girl, Celeste was her name, and I'll tell you the rest of the story in a minute, who had the same chipmunk face. And as I looked at this face, I recognized the children that I had seen in Ethiopia with the nurse that pointed this out to me. And I was like, oh my gosh, like I literally was in shock almost. Could this be that these kids had AIDS? Ah,
Mm.
pediatric AIDS was not a thing until then at all, until this Newsweek cover at least brought it into my life. I bought the magazine, read up on it, and in it was described Dr. Ari Rubenstein from the Albert Einstein College of Medicine in the Bronx, New York, had discovered that AIDS can actually be passed on from mother to baby, and it presents in different forms. Obviously, back then, not much was known, including the swollen lymph nodes, is what actually was swollen there. And so that was the beginning of that insight. And given my, unbeknownst to me when it first happened, firsthand experience to this concept of pediatric AIDS, without me knowing what it was, obviously in Ethiopia, but then in looking at that music thing and realizing that diseases like this, like AIDS, could potentially be passed on from mother to baby. With this, I was really like, wow, maternal child health, this mother fetal newborn diet was the center of my interest at that point on.
Wow, your journey really took quite turn, I think, after your experience in Ethiopia, and I still have the same chills every time I hear you talking about it. It's really, yeah, a great discovery, and the fact to see it in person, it changed your life after that, I think. So now let's hear more about your educational path, like how it shaped your perspective of healthcare and immunology in general.
Mhm. Well, that really began with Professor Ari Rubenstein. After I bought the Newsweek magazine, I wrote him a letter. Back then, I didn't have an email at all, and I wrote him in my letter. I said, I think what I saw in Africa and Ethiopia was pediatric AIDS as well. And he just wrote back in the letter, the only thing he wrote was come. And I was lucky enough to get a scholarship from the German government to go to the Bronx, New York for a year initially. I never returned, I can tell you that now, so I stayed on. But I arrived on a Thursday afternoon, and Ari was originally a German Jew, and he spoke fluent German, so he greeted me in German. Um, uh, and, and we walked to a container lab, a white container. Everything was white in there, the neon lights, the table, the doors, everything. We walked in there, and that's where they saw their pediatric AIDS patients. And we walk into this container, open the door, corridor. He opens the first door to an examining room, typical medical examining room, everything white again. And on that examining table sat that girl from the front page of the Newsweek magazine, Celeste. She's the only cover girl I ever met in my life, and I I was a little bit nervous, as maybe not because of her fame or anything, but I just was never really in the presence of people that had been on cover pages before.
Mhm.
Ari examined her. He took some blood. And after that, we walked back to his laboratory. His office was right next to his laboratory. And as he went back to the laboratory, he gave the blood to some of his staff in his laboratory. And I asked him, "What are you doing?" And he said, "Well, we don't really know what causes AIDS. We do research to find out what makes makes kids get AIDS from their mom." And that moment, and even now as I'm telling you, like having like literally like chills up and down my spine, I was like, oh my gosh, research. To me, until then, research was something that other people did somewhere. Medical books, what was written in the medical books that I learned in medical school was the truth. Like this was it. I didn't realize that you needed to do research to find out what was written in those books. So I was completely hooked, and I stayed on there. And to me, that really was that was the beginning of my MD PhD career. I worked with Ari's protege, Dr. Harris Goldstein, and with Ari and Harris together, we developed models to study pediatric AIDS and transmission, mother-to-child transmission of AIDS. And obviously, in the coming years, HIV was identified and so on, and then that became a lot more um, of an active research stream. And that's where I did my MD PhD. And that's where I never went back to Germany. I stayed at the Albert Einstein College of Medicine. I finished my medical school and my PhD, there's an MD PhD. And it was a great experience. And that really was the beginning of my educational research and clinical combined really journey.
Wonderful. Thank you for sharing this, Sabi. It's really fascinating, and to see how your career started with these key mentors, I think, of you. And but is there any other experience, specific experience that influenced your career path afterwards?
Yeah, towards the end of my training in the Bronx at the Albert Einstein College, I was a nerd, always have been, and still am. So like that's that. I was in the lab alone Saturday evening, um, and looking. And don't forget this because the lab was all dark. It was just me in there. The computer screen was the only light there, and I was just thinking back to myself, I'm almost done. What am I going to do afterwards? And I kind of argued with myself, isn't the right word, but I felt like I wanted to do something. I knew whatever I was going to do, I was going to be full on. Like I wasn't going to do this half-assed. And so I said, like, whatever I do has to be worth the time away from my loved ones, my family, and everyone else. And so it needs to be an ethical, moral, even spiritual calling, a purpose to what I did. So it really very logical, very simple, and then just click. And I thought to myself, who's at most risk to die? from especially infections, but to die. And this is the newborn, and infectious disease is the major killer of newborns other than preterm birth. So then I looked up on the internet, which is back then I had access to then, who was the person most known to work on in neonatal infectious diseases and how to use interventions to protect them. And that was Chris Wilson in Seattle. He wrote the chapters, and he really was Mr. Neonatal Immunology, and still is. Like, he really is the pillar that everybody else is, including myself, builds on. He still is my mentor until today. What a fantastic guy, really. And he was in Seattle at the University of Washington. I wrote him an email back then. That was by then we had those. And I said, I'd love to work with you if I come to Seattle for my residency and fellowship. And he invited me to come. So I went to Seattle, did my training in pediatrics, and then also a fellowship in pediatric infectious disease while working in Chris Wilson's laboratory as a postdoc. And after that training, I was very lucky to land my first job in Vancouver, British Columbia, at BC Children's Hospital. And there were two giants of the field. David Scheifele, who really was the father of pediatric infectious disease in Canada, and also the father of pediatric vaccinology in Canada. Like, really fantastic, working on vaccines in the pediatric age group. And David Speart, who back then was the division head, pediatric infectious disease. And David Scheifele wanted to find out, how do vaccines work to protect from infectious disease? And David Speart wanted to find out what makes children sick. And so I had this sweet spot. I landed between two like superheroes, and had the sweet spot just connecting the two. It was a simple task, really, to figure out how do vaccines actually do what they do, and not just on a population level, but mechanistically. And that's what I did. And that was those three people on my journey. So Chris Wilson, and then David Scheifele and David Speart, really were the absolutely transformative for my future career.
Wow, thanks for sharing this, Toby. This sounds like it's meant to happen. And sometimes, actually, people you meet along the way change your life and even your path forever. From what you told us, it looks like your Vancouver experience reshaped your view on infections and disease.
Mhm.
If I may ask you to share with us, Toby, what aspects exactly of early life host defense are you the most passionate about, and why?
Mhm. Yeah. Um, so that's a really good question, because it really is very central to what we still do now. Um, in Vancouver, as a clinician and scientist, a clinician scientist, I learned that it's not the pathogen, the infectious pathogen, that causes infectious disease. It's the host response to the infectious pathogen that causes disease, for almost all. There is very few exceptions. So if the host is what determines the outcome of an infection, meaning is there disease or is there no disease, that is crazy. Like, why are we only focusing on the pathogen? We should also focus on the host, because that opens up so many other avenues. It does, most conceptually. I mean, the first step is that it empowers us as the host to do something about this. Like, it's almost as if we have the power to make the decision. I'm going to have disease. I'm not going to have disease. And in a sense, that's true. But it opens up so many avenues that we could actually deal with infections beyond antibiotics. Antibiotics target, or antivirals target the pathogen, not the host. And that's good, and that we shouldn't stop doing this. But if you can also target the host to change the paradigm, to change the equation and make disease less likely, you can come up with massive additional interventions that really, really drive clinical care. And that's really what was at the center of my interest there. Just to give you an idea there, you could, for example, maybe a very concrete example, if and sepsis is an overwhelming infection. You have microbes, bacteria mostly, everywhere, including in your bloodstream. And if you and I have an infection with something called E. coli, it's a gram-negative bacterium, frequent cause of sepsis, especially in the newborn age. If we have more than 10 of those buggers per milliliter of blood in our system, we're pretty much dead. We don't even make it out of the intensive care unit. While a newborn can live with 30 to 100 of these buggers per milliliter of blood. And they've developed a system which has been labeled disease tolerance. It's not an immunological tolerance, but disease tolerance, where they kind of ignore the pathogen away. It's not a healthy state and a long-term sustainable state, but it works. And newborn does that really in the end because they don't have the resources, the metabolic resources to fight an infection. To go on and fight an infection full on requires a lot of energy. And the newborn is very, very busy to grow. And it's not just busy because if the newborn doesn't grow, they actually die. Like it's not a choice really. And so by reshuffling resources to focus on what's essential for your survival for the newborn, that's growth, and then dealing with the infection ideally afterwards and not doing much about this before, that's disease tolerance. That is a concept that we in the adult world rarely even consider as a potential beneficial outcome. Yet it could be. Similarly, there's ways that you can do something about this using, for example, probiotics or immune modulation like vaccines, and vaccines not just targeting the pathogen, but as an immune modulator that really allow you to now redirect the host response and with this empower the host to decide over yes disease, no disease, or at least less disease if it's not no disease. That is really the breakthrough ideas and clinical translatable interventions that we now gathered out of the basic research lessons that we learned in the laboratory working in Vancouver.
Transformative insight. So, Toby, considering the concept of disease tolerance and energy expenditures in newborn that you told us about, can you share with us your long term goals and ambitions in the field of infectious disease?
Hmm. Well, the long-term goal is to make these insights that I just mentioned really useful and make them testable, and then with this, then really be something that we could deploy clinically. The most important piece there is again to think of vaccines not so much as they're really good at targeting specific pathogens. That's how they were designed. For example, the tetanus vaccine is going to target the tetanus toxoid, the poison that really causes and the likes. Um, in most cases, how these vaccines do what they're doing, we don't really understand all the mechanisms. But what we do know is that giving a vaccine changes the person that receives the vaccine in a manner that makes them more resistant to developing disease. And that's not always due to reducing the pathogen burden. It changes the entire metrics right there. And you can use similar interventions like probiotics, as I mentioned already. You can give probiotics and make the human host, bring the human host into a different state. You can give different metabolites, if you wish, let's say a glucose drink or medications that have the same effect. And with this, change the state of the human host. And with this, the outcome of an infection. All those tools that I just mentioned, from vaccines to probiotics to potential metabolic additives or even metabolic regulators, they're all already licensed. We already have them in our hands to use. It's not something we need to discover now and 10 years later maybe try it. No, we have them already available to us. So by us understanding the concepts of what drives infectious disease outcome, especially in the newborn, in our case, we can now actually access like a whole range of interventions that have been not even considered in the treatment of infectious disease.
Very simple and effective
Yeah,
interventions that are easy to implement. It's not the problem is not understanding what works and what not. We know what works, and it's simply a matter of
mhm,
implementing it widely. Putting the baby at breast shortly after delivery or giving an approved vaccine within the first days of
mhm.
life can save newborn's life. Yeah, incredible. But before we move forward, Toby, your work in the field is clearly groundbreaking. So could you take a moment to highlight some of the key discoveries or breakthrough you've been part of throughout your career?
Mhm. Sure. Maybe the two most critical ones there are relating to what I just mentioned a minute ago. One is the TB vaccine called BCG, Bacille calmette-guerin. It's the vaccine that's been used the longest in human history, and it's being used the most commonly every single year. So it's 100 million people who get the vaccine every single year to prevent tuberculosis. That's what it's been designed to do. It works okay at best to prevent tuberculosis, but it does something else that's really crazy. It reduces the risk of a newborn to die from an infection dramatically, like significantly, 30+% improved survival, unrelated to TB. And this has been known for several decades now. It's most obvious in areas of the world where infectious pressures. So newborn infections in lower resource settings are prevalent. Therefore, it was very clearly identifiable in Europe some 50 to 70 years ago, or in the United States, and now still in Africa, where a lot of newborns die from infections still. Um, so giving BCG reduces the risk to die, and that's been known. The WHO has confirmed that, but people are not really sure what to do with it because it's not really what you expect a TB vaccine to do. And they said, until we know what the mechanism is, what else are we going to do here? The reason that this is important is that the WHO had said, and rightfully so, unless we know exactly what's going on, we're not going to change the recommendation. The recommendation right now is to give every newborn a BCG vaccine, but only 50% of the world actually get it before they're 1 month of age. Yet the highest risk to die is the first few hours to days of life. So 50% of the newborns right now miss out on BCG. And the WHO has said, unless we know what's going on, we can't really change the policies of how do we administer BCG to more newborns than currently is happening. We identified at least a part of this mechanism. That was one of the big discoveries we had, working with my partner in science as well as in life, Dr. Nelly Amanyobi. We identified that the BCG vaccine, the vaccine that's meant to target TB, actually induces production of neutrophils, a type of host protective cell, within minutes to hours of getting BCG. It revs up like, and these neutrophils are then responsible to protect from infection to begin with, not just from disease, but from infection. So a massive insight that in our head at least makes it very reasonable to consider BCG to be given to every newborn. BCG is a live microbe. It has some risks, any live microbe would be. But if you weigh the risks and balances of as given how many newborns die from an infection versus how many newborns may have a problem when BCG itself may become an infection, it's very clear that the world would benefit greatly. Like literally hundreds of thousands of children would be saved every year if every newborn would get BCG. Um, it's currently not given to every newborn in part because the vial itself is made as a 20-dose vial. And the countries that depend on BCG being delivered to them are only allowed to open them if they have at least 11 to 13 newborns in front of them, which sometimes doesn't happen. And then the newborns that are, let's say, there's only 7 of them today, they're sent away and said, come back whenever. And then they may or may not come back, but it won't be on day 1 or day 2 or day 3, maybe next week or next month. So if just a simple change of this policy of the vial opening policy by the WHO would really already help to reduce the burden of infectious disease. That's BCG. Another topic that we're now actively engaging in is breastfeeding, or especially the first breast milk that is produced by the mother after birth is called colostrum. The data has been, it came out of Ghana first, and the Kintampo Health Research Center, and we work closely with those folks there. They're fantastic. But it's been shown that if you feed a newborn within 1 hour after birth, the risk to die from pretty much anything, but mostly infections, is cut in half. And that's, you just have, if the baby latches on within 1 hour of birth, they get maybe 50 microliters, so 1 drop of colostrum, maybe 2 drops. And colostrum, if you ever tasted it, it actually tastes more salty than sweet. It doesn't really taste like milk at all. There's many cultures that throw it away because I think it's something that isn't good to eat and so on. So even though the data has been out there, it's been confirmed in many other countries, and it is WHO policy that it's recommended for every baby to be put on the breast within 1 hour of birth because it reduces the risk to die by half. By the way, there is nothing in the whole medical intervention armamentarium from birth till end of life that's as effective as colostrum. It is effective. It's designed by Mother Nature, not by humans, and that's probably why it is so effective. But the only 50% of the world's newborns get put on the breast within the first hour, and not many more even within the first day. And that's a massive loss. And the reasons are obviously complicated. There's cultural reasons, as I mentioned. Sometimes the mother is sick or dead. Sometimes the baby is very sick, let's say in an intensive care unit, a premature baby. Not every baby can be put on the breast right away. Even though we know that this is the most effective medical intervention, end of story, we have no idea what it is about colostrum that provides this massive protective effect. We don't know at all. So this is something that we have worked with now with Professor Valerie Verhasselt, who is really an expert on the impact of early life breastfeeding on immune development. And together with her and others around the world, we're now deciphering what the mechanisms are. And with this, then hopefully have a nature-inspired substitute that could be given to those that can't be put on the breast. And I think those are the 2 topics in my head that are really massive, have massive potential, not just because they're massively impactful in terms of lives saved, but also the mechanisms that come out of the deciphering what's going on there are really incredibly informative for much more to come.
Again, two very easy and simple intervention proven to work that can be easily implemented. Actually, hearing you talking about BCG reminded me of a personal experience. Knowing all the work that you do on non-specific effect of BCG at the time, I tried to give BCG to my baby in a country where it wasn't a vaccine part of the schedule. I simply couldn't. I remember going to the center and asking them to give it to my baby, and they were questioning me why I wanted to do that, and they ended up not giving it to my baby at the end. So I truly believe that this is an impressive discovery, especially the extensive work you and your team did and still do through clinical trials and mouse work on non-specific effect of BCG. With that type of, if I may say, against the dogma and paradigm
Mhm.
shift discoveries, are there any challenges you faced during your career in research? And if yes, did you overcome them?
Mhm. Yeah, so that well, and if I just take the two examples that I just mentioned, the breastfeeding, immediate breastfeeding, and the BCG. Maybe with breastfeeding first. So despite the fact that breastfeeding has been known for at least 25 years to be so immensely effective, and as I mentioned before, currently there's less than 50% of the babies in the world that get put on the breast even within the first day. The reason for that are there's many reasons. It's complex, but one of the contributing factors is actually a pretty sad story there. The formula industry. There's more money spent on formula advertising, especially in low middle income countries, than there is on maternal child health research. Just let me say this one more time. There's more money spent on formula advertising than on maternal child health research combined. And this is a massive. I mean, it's unethical. I mean, just like tobacco industry some 50 years ago knew that smoking causes cancer. The formula industry knows that putting the baby on the breast within an hour of birth can save up to 400, 500,000 lives every single year. And they're actively working against it. So it's undermined even in the hospitals in the rural areas of the world, in the poor areas of the world, where formula is peddled. Formula is seen as a status symbol, like and because the market has positioned it like this has to stop. There was a series in the Lancet published not so long ago that really outlined this current practice of the formula industry, and it's by design. This is not by accident. Um, and I think the regulators around the world, governments around the world, just need to step up and stop this now. I mean, this is not going to happen overnight, just like smoking didn't disappear overnight, but it can be changed. The second, so it's money in the end. Sorry, if I may add, for industry is they make money with that, and so it's clearly profit that stands in the way of saving those lives of young lives. The second one is a little bit more complicated, but BCG, as I mentioned, can reduce up to 30% of neonatal infectious deaths in areas of the world where there's a lot of infection. And it is currently recommended by the WHO, but as I mentioned before, with the vial policy, not really pushed as hard as we could in the world. And that's mostly because there's many folks around the world that still think of a vaccine targets one pathogen and that's it. So it's this dog thinking amongst folks like myself. It's really it's this boxed in thinking. And because of that, the system is not willing to accept the fact that a vaccine such as BCG, which really is more of a probiotic in that sense as a live vaccine than a real vaccine, um, a vaccine can do much more than just target the pathogen, and this that it's designed to attack. So it really is the system here that stands in our way, and our inability to conceptualize beyond what we feel fits neatly in a box. So this, I think, also in both of these cases, but especially for BCG, having an unbiased approach, collecting data, letting the data tell you what does this vaccine actually do, and find out how it protects it, which is how we approach this. So an unbiased, data-driven approach would really allow us to change. So money for the formula industry and an encrusted dogmatic system for BCG. Those are obstacles. And if I may point this out, like both of these obstacles really need human skills because these are human relationships that constitute these obstacles. It's not lack of scientific insight or lack of research. It's the people in the world that need to human relationships that need to change to make this work. And that's a skill that's a lot harder to come by. And like us in graduate school or in medical school, we don't really learn a lot about this. And I think that's we need to work with experts in the field that can help um, change relationships to improve early life outcomes.
Yes, thanks, Toby. Real challenges indeed, especially dealing with the formula industry and policymakers. Knowing that the relative cheap cost and easy implementation of these two interventions is really sad to see that is not being implemented easily. So, Toby, based on your rich experience, what advice do you have for young scientists aiming to make a difference and impact in neonatal health research?
Yeah. So I mean, I did my MD PhD at the Albert Einstein College of Medicine. It was Albert Einstein when he was hailed as a hero with the relativity theory of relativity. When he said, "If I could see further, it was because I stood on the shoulders of giants," and I think that this is very much true today as well, and not just for me, obviously, but we're only if we work together amongst experts in large networks are we able to actually achieve what we set out to do. This whole concept of the lone cowboy style um, science, it's just not, this is not going to really advance our field as much as we need to.
Solid advice, Toby. I cannot agree more with you. Working with a diverse range of experts in the field accelerates discoveries and even enriches everyone's experience. Looking forward now, what excites you the most about the future of neonatal health and early life interventions?
Uh-huh. Yeah, I mean, there is the most exciting piece, I would think, at this point, is that the insight that much of what happens in the first few hours to days of life is already determined before the baby is born. And with this in mind, so in utero, while still inside of the mom. So really, interventions that target the newborn when the newborn is most fragile, which is literally in the first few hours to days of life, you have to start with the mother. And their interventions, such as maternal vaccination, nutritional interventions, and the likes, really help set the trajectory on target to give healthy term delivery to a healthy, robust baby, healthy mom, healthy baby. Um, these are all nice phrases, but we now have the tools to actually make that happen. We can monitor um, pregnancies throughout and really help empower each pregnant woman to really drive this forward. And one of the major tools that works in this direction is maternal vaccination. And I think this is something working with the experts in the field, Arnaud Marchand and Sing Sing Wei in particular, we've looked at this and really have focused on maternal vaccination as one of the examples. There's other interventions like nutritional interventions and the behavioral interventions and so on. But there is a whole host of things that we can do during pregnancy that not only help the mother have a healthy pregnancy, which is obviously a primary concern, but also then to have the baby have the best start of for life. And I think that is what I see coming in the pipeline right now is an increased focus on interventions during pregnancy to ensure that both mom and baby really do fantastically well.
Fascinating insights from great minds and great review you pulled up here. Working alongside Arnaud Machon and Sing Sing Wei can only promise a profound impact in the field of mother and baby diet. Before we wrap up, Toby, any upcoming specific projects or area of research you are particularly enthusiastic about?
Yeah. So the one that I already mentioned is monitoring pregnancies, and especially in remote, difficult to reach populations, which translates into tools that are you doing this non-invasively, from a smart wristwatch to measuring biowearables, so biosensors, wearables in general, or even measuring the breath that allows you to really get a good assessment of of a pregnant woman's metabolism. Those are all things that we can do right now that allow us to monitor, I mean, not just us, but allow one to monitor pregnancies remotely, even at home. And that includes remote as in far away populations and or difficult to reach populations, inner city neighborhoods that have socioeconomic disadvantages. I think those are all options that are coming on the table right now. And with this remote monitoring, non-invasive remote monitoring, we're actually not only going to increase our understanding of what's going on, but also will know what intervention when given when works best. And this concept is, I think, going to just overtake the world. I mean, we all started recognizing that remote monitoring, remote medical visits, even during COVID, work quite well, work reasonably well. And then using AI or artificial intelligence, machine learning algorithms to, out of this wealth of data that we can collect about ourselves, extract insight that is something that we, as the end consumer, let's say, for example, if I were the pregnant woman and I'm wearing a smartwatch, my iPhone, and the would tell me, okay, you did this and that and here, but it would be better for you if you could do this and that and here. So we can empower each person to, in this case, each pregnant woman to help ensure the best possible pregnancy outcome. At the same time, obviously, have medical staff look at this data as well remotely, and if there's alarm signals, trajectories, they can then um, triage high risk pregnancies towards more frequent visits or potential specific interventions and the like. So it's going to save massive cost because only those that need it would be asked to show up. And then also we understand what intervention to give to whom, when, where, and why, from giving glucose, giving to vaccines to whatnot. But most importantly, and I think that's a crucial element in all of this, is we would bring sovereignty over pregnancy. We help give it back to the woman, to the family, to the community. And I think this is something that, as pregnancy has been increasingly medicalized over the last decades, and without much improving outcome, by the way, just to note on the side, really is by empowering each pregnant woman to be in charge or collect the data of her own and interpret her own mind. So human intelligence and artificial intelligence combined. So a hybrid intelligence model really, I think, is going to drive the future in much of this area.
Indeed, Toby, your vision for the future of healthcare data collection is spot on. With the boom in artificial intelligence and its huge potential to accelerate research, this has to happen. The shift from invasive to non invasive methods, together with the integration of AI, opens up a whole new frontier in understanding human health. Your insight have us looking forward to transformative changes in the field. Thanks for sharing your forward thinking ideas with us, Toby, today. Any last comment to our unscripted audience?
Yeah, I think that, I mean, there's two things to be said. One, a little bit more of an abstract statement first, and then a very concrete example of that. So the abstract sentence, abstract statement is that I think many younger scientists, clinician scientists, researchers can feel overwhelmed because there is so much new, I don't know, data, even like just like paper after paper. tool- How are you going to stay on top of this, and how can you ever actually make a difference? And really, I think that what the crucial element there that I learned over my career now is that if you can see it, you can be it. I mean, that's that famous song, and it's very easy, but it's actually true. And the crucial element, the point I wanted to make with this is your passion, your vision will find you. It's not the other way around. So recognize, because if you don't have a vision of, oh, I want to do this work on this topic or something else, that's okay. Just totally fine. Just expose yourself to as many different environments as possible. Get yourself out of your comfort zone and expose yourself. And with this, you will see, and that at some natural point, and this is different from person to person, that maybe when you're 20, maybe when you're 60 or 80, it'll come to you. It'll find you. It's like predestined to find you, and it'll find you when it's the time. So just give itself. You have a lifetime to do this. And then the very concrete example there is an initiative that we started recently, the Born Strong initiative. And I think this is really a perfect example of what I mean with this vision. Like, okay, I'm reasonably far advanced in my career, and I only realized in the last few years that focusing on the mother is actually the best way to help the baby, which sounds ridiculous to anybody on the outside, but I have to admit this. And it's totally obvious, but it took me a long time. And now working with the experts in the field that have coalesced in this Born Strong, really the most conceptual leaders of the field, that the thinkers of the field that can see into the future, and they bring the future to us right now. And they all work together in this Born Strong initiative. And what's so amazing about the Born Strong initiative is it's not about me, I, and myself. It's not about any one of the top-notch scientists and everything. It's about them sharing their insight and even sharing data and samples to achieve this common goal of having a healthy mother give birth to a healthy baby, and with this really ensure an optimal start for a new life. That's what the Born Strong initiative is, and that really was born out of the vision that we need to work freely, unrestricted, data driven, not dogma driven, to go on the topic that, and I'm going to stress this in the closing statement here, which is the longest, deadliest. It's not a pandemic, it's not an infection, but burden to the human race, which is adverse pregnancy outcomes. For example, stillbirth, miscarriages, obviously, and then preterm birth. Like it affects at least 10%, if not 20% of all pregnancies, and it is the number one risk factor, not just for early life death, which is how I got to know about this, but for death across the rest of your life. What you and I are at risk of right now in our advanced ages was in large part, if not completely, determined during pregnancy, and therefore that is the period where us focusing on helping direct this trajectory early is going to have the biggest impact. That is what the Born Strong initiative is focused on, and it's open to anyone who's interested in it. The website is accessible, and it's one of the most fulfilling and at the same time thrilling endeavors that I've ever been a part of.
If you can see it, you can be it. I love it. I truly think that the Born Strong initiative is inspiring. It's bringing together outstanding experts ready to share knowledge, insight, and even their resources to make an impact on baby and mother's health. Looking forward to seeing the impact of this initiative, really, Toby, and hearing more about it maybe in the next coming months. We can maybe have you here talking about it. Thank you very much for sharing your insights and your personal journey and story with us today. This is definitely inspiring all of us and inspiring young scientists for taking a similar path.
My pleasure. Thank you.
So, friends in science, as we wrap up this great conversation with my friend, Professor Tobias Kollmann, I encourage you to reflect on the transformative ideas we've explored with him today. The future of healthcare and research hold exciting possibilities. Stay curious, stay tuned, stay informed, and join us for more insightful discussions on our upcoming episodes. Until then, take care and keep exploring the frontiers of research and uncharted territories.